All right. So the second session, is on haploidentical transplantation in thalassemia. There'll be some repetition, but I'll tell you why this repetition is there. There are some things I wanted to kind of highlight and bring in picture before going to the core haploidentical transplantation in thalassemia. So why we're discussing this? Because as we know that only 20-30% of the times we'll have a family donor, a sibling donor for the patient who's a full match. And then what happens the rest, maybe 10-20% of the times we may find a unrelated donor from the registries. But then in the next 50-60% of the patients, there is usually not a family matched or an unrelated donor. So I think in those patients, haploidentical transplant is an option. Now, for any transplant, whether it's haploidentical transplantation, matched sibling, unrelated, thalassemia, as I said earlier, is a very complex disease when it comes to transplantation. We have to look at various aspects when a transplant as a treatment or a curative option is brought on the table for discussion with the family. It's not only about finances, which are very important in our setting, but also the risk valuation of the patient, the quality of life he's having now, and what's the quality of life expected post-transplantation, the risk of chronic GVHD, which can be itself a debilitating long-term disease, and of course, availability of the donor, age, and other risk factors, which Dr. Sunil has very nicely highlighted. So the counseling and the discussions which are on the table with the family are very, very complex, and I think a lot of time needs to be spent on that, so that everyone understands, what we are getting into. Now coming to the haploidentical transplantation, what are the advantages? The advantages that we have got immediate donor availability. The donor is next to you. For every child, both parents are, are haplo donors. So practically, every patient will have a donor for them. In older patients, that usually it's about 80 to 90% times we'll have a haplo donor, but usually for children, we always have a donor option available for them. Another advantage is that donor is available for second transplant if required. Donor is available for any DLIs later on, and potentially less expensive probably, as compared to unrelated donor registered transplants from registries where the expenses of the registries are quite high. But the major obstacles are, that we are doing transplant across the HLA barriers, and hence graft rejections, graft versus host disease are very, very important. GVL doesn't really apply in our, thalassemia transplants, but of course, slower immune recovery and increased infection risk is another obstacle when we offer an haploidentical transplantation for a patient. Now, what are the unique things when we talk about haploidentical transplantation in thalassemia, and for that matter for any non-malignant disease? There are a few things very, very unique, and they need to be kept in mind, because most of the data, most of the discussions which happen, especially, I would say in adult platforms and also in the platforms of international conferences, they're quite heavily, biased towards malignant transplants. But in non-malignant transplants, you're dealing with a very, very immune competent host, and that immune competent host can be highly sensitized, which can happen in thalassemia major, for example, due to repeated blood transfusions, and which leads to high rejection rates. We have no need for graft versus host disease because we don't need any graft versus leukemia effect in normal disease. And there are a lot of ethical issues which probably need to be answered and discussed with the family before a transplant is embarked on, especially haploidentical transplantation. Now, this slide is important because that's something which we exploit in a transplant setting, and especially with a mismatched transplantation. We know that the stem cell graft which is put in doesn't only have stem cells in it, but it does have other cells, the B cells, the T cells, and the NK cells, along with the graft, and the T cells which are present in the graft. The majority of them are, 95% of them are alpha beta cells, but there's minority cells, about 5% of them are gamma delta cells. And this is very important because we can exploit this when we do graft manipulations in a haploidentical transplant setting. Now, every transplant, is an interplay, or it's a fight between the donor and the recipient lymphocytes. The donor lymphocytes, are important for engraftment. They're important for fast immune reconstitution. They help in relapse. Of course, not relevant in thalassemia, but they also mediate graft versus host disease. At the same time, the recipient lymphocytes are important because if they are there in the system and they're strong, they're going to mediate graft rejection. So this is basically, these two lymphocyte systems have to interact with each other, have to really fight with each other so that the transplant is successful and there is no residual effect in the terms of graft versus host disease in the patient. Now, how do we achieve that? How can we do a haploidentical transplantation, keeping these graft components in mind and the different lymphocytes subsets in the mind and what they do from their function point of view. Now, we can do T cell depletion, which is ex vivo T cell depletion, and that can be done by indirect T cell depletion. That means you're just selecting the stem cells, which are CD34 stem cells. You can also do direct T cell depletion. That means you're just taking the T cells out from the graft. And it has evolved over a period of time. Initially, you used to take all the T cells out, which is called as CD3 positive T cell depletion. Then we started doing the CD3 and CD19, that means B and T cell depletion together. And now recently, we are trying to do alpha beta depletion and leaving the gamma delta cells behind and doing CD19 depletion. That means you're doing partial T cell depletion, leaving the gamma delta cells behind, which are not supposed to mediate graft versus host disease, but have anti-infective properties and help in immune reconstitution and engraftment. So that's alpha beta depletion. But then we also nowadays do alpha beta depletion with CD45 RA depletion. So this I'll explain a little bit later on, where when you do CD45 RA depletion, you're leaving behind memory T cells, which are CD45 RO cells in the graft. And these again have anti-infective properties that help with robust immune reconstitution. So these are the in vivo T cell depletion methods. What about the ex vivo T cell depletion? What about the in vivo T cell depletion? In vivo T cell depletion can be done by two different strategies. One is the Chinese strategy, where they use a lot of ATG during conditioning to do in vivo T cell depletion, and that they use for the haplotransplant settings as well. And there's the more common and the more studied and accepted way is doing allo depletion with cyclophosphamide, what we call as post-cy or post-transplant cyclophosphamide. So this is the cartoon showing exactly the same thing, how the T cell depletion has evolved over a period of time. As I said earlier, it will be initially just CD34 selection, then it has become T and B cell depletion, leaving behind stem cells and effector cells like NK cells. Now, when we do alpha beta and CD19 depletion, we are having stem cells in the graft. We are having effector cells like NK cells and gamma delta T cells. And as I said, the last one, that's T cell alpha beta and CD45 RA depletion, we're having stem cells, NK cells, gamma delta cells, as well as CD45 RO, which are the memory cells in the graft, which are going to the patient. So this has evolved, and it's very important to understand that, because the data which is there on haploidentical transplantation is going to be read in the context of what technique you have used, and that's very, very important when we interpret that data and apply that data. Now, this is a cartoon again showing the T cell alpha beta depletion for you. So this is the whole stem cell product which goes through this Clinimax device. It takes the alpha beta cells out, which gets stuck to the magnet, and then the rest of the product goes down, which is stem cells, NK cells, dendritic cells, gamma delta cells, and this is the graft, and this is given to the patient. Now, post-transplant cyclophosphamide, again, I don't need to tell this audience, very well-defined methodology on day 3 and day 4 of the transplantation. You cyclophosphamide 50 milligram per kg for two days, and what it does that it kills the alloreactive T cells, and the stem cells are spared because cyclophosphamide doesn't act on the stem cells, and hence removes alloreactive T cells. Are a very effective strategy of doing graft versus host disease prophylaxis in a haploidentical transplant setting. Now, getting into the core topic of thalassemia major and how this, whatever we just discussed now, can be applied in thalassemia major, and what is the data. Now, this data was showed by by Dr. Sunil already. This is the largest look-review series which they published for over 900 odd patients. They could prove over a follow-up of over 20 odd years that about 73-74% patients can be cured long-term, and this is data from 1982. And so this kind of for the proof of the principle that transplant can be curative. But they also showed that transplant in thalassemia is a very heterogeneous disease, and the class 3s do not do as well, which Dr. Sunil nicely showed. And the outcomes can be as poor as 60 to 70%. In fact, 60 odd percent in our settings from India, and what they showed here was 70-75%. And this again has been shown that when we when it was looked by Dr. Vikram Matthews at CMC Vellore, and what he showed is that class 3s in fact are two different categories, and class 3 high risk outcomes can be as low as 20%. Now, I'm trying to highlight this here. Why I put this here in the haploidentical transplant talk is because, if you see here, outcomes of the class 3 as such is about 60% odd. And and the high risk class is the outcomes as poor as 20% odd. But we were doing transplant for these patients also that point of time. But as we learned, as we retrospectively looked at the data, and then we made some changes which which were like this. For example, protocol 26 adopted by the Italian group, where they introduced some preparation prior to transplantation, highlighted by Dr. Satindra already, that we could increase the outcome of these patients by around 10-15% odd. So the point I'm trying to make here is that it's very important to prepare the patients, and as per the risk stratification at the transplant type, to make necessary pre-transplant modifications, pre-transplant alterations or whatever additions to make the transplant more successful. And this is the data which again Dr. Satindra highlighted. This was a multi-center data which was presented a few years ago in ASH meeting, where it was again shown that using triasulfan-thiatepa versus busulfan cyclophosphamide, you could see almost a 20-25% outcome difference. And again, the point I'm trying to make here is that the outcomes were as poor as 40-45% in this data series from the multi-centers from all over India. When we go to unrelated donor transplants, when we see the initial experience, which was again Italian experience by the Pizarro group, what they showed is that the event-free survival, look at the event-free survival, 21%, survival was 65%, a lot of rejections and a lot of mortality. This was the initial experience of unrelated donor transplant with thalassemia major, not very good. A few years ago, the same group published a little bit better data. The survival had gone up to about 80% and the cure rates about 65-70%. They also showed in unrelated donor transplants that the class of disease also matters, and class 1, class 2 do better than class 3, even in class in unrelated donor transplants. But over the period of time, the outcomes in unrelated donor transplants also improved. This is the data from Thailand, where they showed excellent results with unrelated donor transplants to the tune of about 80-85% thalassemia-free survival. This is data from China, where they kind of compared this unrelated with matched sibling, and the outcomes were practically the same in the two groups, where they used a fully matched unrelated donor transplant and compared to the matched sibling transplant. So the point here trying to make is that even in unrelated donor transplantation, the outcomes have evolved over a period of time, and now with a 10-by-10 matched donor transplantation, you expect outcomes as good and as equal to a matched sibling transplantation. But it was not the case with the first series, where the outcomes were as low as 20-odd%. So same is the story with haploidentical transplantation in thalassemia as well. The things have evolved over a period of time, and this was the first paper which came up in from the Lucleri group on haploidentical transplantation thalassemia, where they did is that they adopted the T-cell depletion strategy. For few patients they used CD34 selection, but in a few other patients they used CD34 selection as well as some T-cell depletion from the marrow. So you use a combination graft in some patients. But their experience, it was a good proof of principle that haploidentical transplantation can be done in thalassemia major also. So that was a plus point of the study. But as you could expect, 60% patients were cured of thalassemia, 90% survival. So there was about 30-odd% rejection in this group of patients. So most of the patients survived, about 60% could be cured as well, but there was a very high rejection risk. And this was, as I said, a landmark study, not because the results were excellent, but because it just paved the way and set up the ground for the haploidentical transplantation in thalassemia major. Now, there were a few papers which came post that, and this was a paper from Franco Locatelli group, again from Italy, where they used the TCR alpha beta depletion, not the pan T-cell depletion, but they used the TCR alpha beta depletion. And that's why I was telling you earlier, it's very important to understand the context of the data, what strategies have been adopted and what era the data belongs to. Now this was a 2014 publication, alpha beta depletion and this was not for thalassemias only. This was the non-malignant disease taken all together. And with T-cell alpha beta depletion, they could demonstrate excellent cure rates to the tune of 80-85%. And this again, I kind of show the superiority of this depletion technique over the previous depletion technique. Now again, some data from Italians, where they use the T-cell alpha beta depletion for hemoglobinopathies. And again, the outcomes had improved from the previous data set. Now the cure rate's about 70% and the survival is on 85% with the T-cell alpha beta depletion. Still, we had about 15% graft failure even with this technique, and this continued to be a problem in the earlier data in the haploidentical transplant setting. Now, what has been our experience? This is our experience for T-cell alpha beta depletion. This was our first, experience. We presented that in ASH meeting in 2017. This T-cell alpha beta put all together for non-malignant patients. We had a cure rate of this about 70%. Malignant and non-malignant. Non-malignant was a little bit better, about 77%. But again, in this series, we had a little bit higher rejection rates. As it was demonstrated by the Italian group. So only 77% patients could be cured, and they, about 10 to 15% rejection rate. Now, I just want to share with you a story which was a learning for us, and I think this is something which, kind of also, helped us a lot in modifying what we're doing. So, when we started the T-cell alpha beta depletion protocol, like the Italians had, that way back in 2014, this was, first case went very well. The second case is this what I'm presenting to you, 5-year-old thalassemic boy. Very intense conditioning is used under that protocol, flu-cy, thiotep, ITG, cyclosporin was GVG prophylaxis. We did CD4 dose. It was a T-cell alpha beta depleted transplantation. CD34 dose was about 12.7. The patient engrafted on day 13 and platelet engraftment happened on day 10. Very brisk neutrophil and platelet engraftment. This patient on day 15 started to have some fever, and we could see that gradually his neutrophil and platelet counts were dropping. Because it was particularly dropping counts, I was worried about rejection. We did a FISH study at that point of time, and that was 100% donor cells. The fever continued. He had some rash on his skin. We ended up doing a bone marrow. It showed macrophage activation syndrome with high ferritin levels and high LDH. And at this point of time, FISH was also repeated, which showed 100% donor cells. This was a marrow which was done first time, and we could see some in the left, cartoon here is that there's some HLH going on in the marrow. We started methylprednisolone inhibitor of HLH. There was transit improvement clinically, some increment in neutrophil and platelet count, but then his counts again started dropping and he became cytopenic. Again, on day 39, we did another marrow, which again showed less cellularity but very florid HLH still in the bone marrow. So we thought it's a refractory HLH, and that's leading to these cytopenias and the fevers ongoing in, and we kind of increased our HLH treatment. We started ATG and dexamethasone. The child on day 49 had respiratory distress, desaturation, X-ray showed ARDS. This time when we repeat the FISH, it showed 85% donor cells. We tried to give autologous stem cells to this patient, but there was prolonged neutropenia and neutropenic sepsis, and the patient succumbed to this. And just before the death of this patient, we had taken a sample again for chimerism, and that chimerism showed. And this was his last marrow before death. It shows very, very hypocellular marrow. Now, HLH activity has also come down, and his chimerism had dropped down to less than 5%. So this was basically a case of rejection, which had manifested itself as a haplostorm. And that time we were not very, kind of familiar with this entity. The second case, which was followed, that had almost a similar picture. He had HLH in his marrow, but this time we're a little bit, kind of prepared for this, a little smarter, I would say. We salvaged this patient by autologous stem cells, and we had to stop with haploidentical transplant for thalassemia at that time. This is 2014. But at the same time, we didn't see this phenomenon of haplostorms and rejections manifesting as HLH happening in malignant transplants. So malignant transplant program continued, and we used the T-cell alpha beta depletion for them, but we didn't see this approach. So then we thought there's something different, which is in the two. And one of the differences is that the patients with leukemias and malignancies are immunocompromised when we start transplantation. So we started this protocol where we used a pre-transplant immunosuppression strategy in these patients who are undergoing haplotransplant for thalassemia. So what was this protocol is that the idea was to, avoid this haplostorm happening and the rejection happening in the form of haplostorm. And we used this pre-transplant immunosuppression strategy of cyclophosphamide, fludarabine, and dexamethasone. We gave that fludara for 5 days, dexa for 5 days, and cyclophosphamide day 1. Every 15 days, we did it for 3 times. And then after that, we would let them recover, admit for conditioning. post that. And we were surprised with the results. So we had this broad group of patients. Majority of the patients had haplotransplantation with alpha-beta depletion, but some patients did also have post-transplant cyclophosphamide as a GVHD strategy. And 15 odd patients. This is a few years ago when we presented it. That time we had about 15 odd patients with this. Majority of these patients were class 1 or class 2 patients. And what we saw is that conditioning was myeloablative in all these patients. Based on flu cyclophosphamide, and some patients received APG, and some patients with TBI conditioning. And the patients who had T-cell alpha-beta depletion transplant, we tried to use mega doses of CD34, and 16.6 was the median dose of CD34. T-cell replete transplant, that's post-transplant cyclophosphamides, it was the median dose of about 5 million per kg. And to our surprise, all these patients engrafted. 15 out of 15 patients engrafted. There was acceptable graft versus host disease. No major problem except for a little bit higher risk of graft, CMV reactivation, which would expect in a haploidentical transplantation setting. And all the patients, all the patients except for one were cured as well as alive. So there was a survival of about 92%, both thalassemia-free survival as well as overall survival. One patient died with adenoviral infection, and that was only mortality in this group. So this was a small cohort of patients. And in fact, now we have, with this technique, more than 50 patients who have had pre-transplant immunosuppression with thalassemia major and haploidentical transplantation, and these results still hold the same, as they were at that small group of patients of 15 patients. So what it showed is that with this pre-transplant immunosuppression in a haploidentical transplant setting, it is well tolerated. It can lead to sustained engraftment and low rejection rates, and can lead to improved disease survival. So this history was important because it helped us to understand how we can deal with these patients. Those who have got very high rejection rates with haploidentical transplant setting. Now, similar kind of strategy. This is now a paper from Thailand. What we call as famously called as Thai protocol, where they use a similar strategy, although they didn't use cyclophosphamide, which we have used in our study. We were not aware of this data, in fact, when we started that in 2015, and this kind of came after that. This was fludarabine dexamethasone 2 cycles, followed by a conditioning which was based on ATG, fludarabine, busulfan, and post-transplant cyclophosphamide. So they had used in all the patients post-transplant cyclophosphamide. The initial data, which was presented as an abstract, was about 15 odd patients. 14 had successful engraftment, and only 1 patient rejected out of these. So, mind you, we are talking about haploidentical transplantation in a thalassemia major. 1 rejection out of 15 is excellent. This data was again presented, and published later on, and this they had added more patients. I think the paper which was published later on had more than 30 patients, and this data was holding true with overall survival and event-free survival of about 94-95 patients in the haploidentical transplant setting. So just by introducing one concept of pre-transplant immunosuppression, both in our experience and the experience which the Thai group has shown, the outcomes could be made to the tune of 90-odd%, which is almost as good as a patient with MATS and donor transplantation. Now, the second question which comes in the mind, I think, is I think there's a debate which goes on, is that, is haploidentical transplantation experimental in thalassemia? Is haploidentical transplantation something which can be offered in thalassemia? I think, I tried to look at this, and there are a couple of, I would say, guidelines which are available. One guideline is from the European Society for Bone Marrow Transplantation, EBMT. There's also guideline from NHS, and what they both say, and if you see this, there's a recommendation here. This is from the EBMT. They say alternative donor or haploidentical transplantation is basically a clinical option, and that same degree of recommendation is kind of applicable for unrelated donor transplantation as well. Only a match-fitting donor transplant, as per EBMT recommendation, this was 2015, is a standard of care. But unrelated donor transplant and alternative donor transplantation or haploidentical transplantation, it's a clinical option, so can be offered as a treatment option. This is basically the recommendation from our NHS, and they also, for haploidentical transplantation with thalassemia major, as well as for unrelated donor transplantation, it's again is kind of put here as a clinical option. So of course, in thalassemia major, transplant is always an option. I would say even mass sibling is an option, because it's if family chooses to to take a transplant as a curative intention, then it can be offered to them. But patients can have an excellent quality of life with blood transfusions and good chelation, with good quality of blood. So it's always an option. I personally feel, and if you go at the guidelines, it doesn't anyway say it's it's experimental now. I think we have got enough data now, which I showed you, that it can be offered, and the outcomes have really improved in the recent times, and the recent outcomes are in the range of 85 to 90%. Now, what happens, in the context of the neutrophil engraftment? I think this is one of the, just put a couple of slides, how we compare the two. This is our experience, our center, because we had done almost equal amount of T-cell depletion and post-transplant cyclophosphamide transplants. And we have seen that in T-cell depleted transplantation, the neutrophil engraftment is quite brisk. About 10-12 days they engraft, and which is delayed by a few days in post-transplant cyclophosphamide, and we all know how important that is in the context of our country. We also see a better and brisk platelet engraftment versus PTCY, because the cell doses used here are quite high, the stem cell doses, and that's statistically significant as well. The second question, which is always asked about immune recovery. We all know that immune recovery post-haploidentical transplantations are poor as compared to a massive transplant, and also to an extent as compared to unrelated donor transplant, a fully matched donor transplant. So we did some work about immune recovery at various time points, which I mentioned here. And this is the immune reconstitution of depleted transplantations, ALCs, lymphocyte count, NK cell, and CD4 count at 21 days, 3 months, and 6 months post-transplantation. If you see at 6 months, they're relatively in a reasonable good numbers, although still low, but then there's a reasonable recovery of all the immune cells by about 6 months post-transplantation. We try to also compare the post-transplant cyclophosphamide with T-cell alpha beta depleted transplantation. If you see ALCs here, by 3 months they are almost same. Although at 3 months the PTCY group, the ALC recovery is a little bit faster. NK cells, we know that NK cell recovery is very, very brisk, very, very fast in T-cell alpha beta cells, and this is very important earlier in the transplant, especially malignant transplants where you can mediate graft versus leukemia effect. And by 3 months and 6 months, they are both comparable, and that's the case with CD3, CD4, CD8, as well as CD20 cells. That usually, by 3 months and 6 months, they kind of are both comparable. So I think from the immune recovery point of view, I don't think there's much difference in the two groups, T-cell alpha beta as well as the post-transplant cyclophosphamide. Now coming to the last kid on the block, which is the alpha beta and CD45 RA depletion, where what you do is that you do T-cell alpha beta depletion on one fraction of the cells, and then they take a small proportion of cells where you do CD45 RA depletion, because you leave the CD45 RO, which are the memory cells, in the graft for the infusion. So you infuse basically two allocates. One is for the T-cell alpha beta, and then one is for the CD45 RO infusion. Now what are these? These are memory cells, and what happens, these memory cells can be given by two different approaches. One is that at the time of transplantation, you can give them at day 0 along with the graft, or we can also give them a little later on. We can give T-cell alpha beta depleted cells here, and we can give these CD45 RA depleted, which are the CD45 RO cells here, as a DLI, which can be given a month post-transplantation as a DLI strategy. Now both have got their pros and cons, but what is very important with this strategy is that this helps you to give a large number of memory T cells along with the graft or later on, and which helps in rapid immune recovery, reduces the chances of viremia, enhances T cell recovery, helps with engraftment and better immune reconstitution, and probably helps in the less viral infections also. We have been doing this for the last couple of years now. May 2018, we started T-cell alpha beta and CD45 RA depletion. 18 patients of thalassemia have had this transplant, and as I said earlier on, we use PTIS, post-transplant immunosuppression, for all the patients of haploidentical transplantation in thalassemia now. And we found that with this depletion, we get a profound depletion of both CD45 RA and T-cell alpha beta depletion with Sclenimax device. It's very feasible, well-tolerated procedure. Out of these patients, 18 patients, 17 are alive, 16 are cured of the disease, and everyone engrafted. There has been no acute GVHD, and the incidence of viremia has also significantly come down. So I think we need definitely more number of patients, but I personally feel that giving this memory T cells back does help, in the better immune reconstitution infections. For the want of time, I'm not going to discuss all this here, but then in the haploidentical transplantation setting in thalassemia, there are various other considerations to be kept in mind. Donor selection, who's going to be the donor, mother, father, sibling, that's something, is by itself a big topic. Role of donor-specific antibodies and desensitization is, I think there's a question in the chat box, which I thought we'll discuss later on. This again, very important in the donor selection. Appropriate conditioning, I think Dr. Satendra nicely highlighted it. So it's very important to understand, what kind of conditioning tailored to the patient's, age, risk stratification, and also type of transplantation. We need to tailor it according to the transplant type we're offering. There's a problem of rejection and mixed chimerism, and that's more in the haploidentical transplantation setting, and that's something we need to keep in mind. And hence, post-transplant, pre-transplant immunosuppression, which was alluding to earlier, is an important aspect to help curtailing the rejection. Post-transplant immune reconstitution is going to be definitely poor and delayed, so we need to be prepared with that. Viral infections are going to be a problem. And as very important is that counseling and understanding of the family of the whole process is very, very important, because the long haul, it's not like math siblings. You reduce your guard after 3 months post-transplantation, but haplotransplant setting, your intense guard, follow-up, and all that has to be conducted for at least 6 months post-transplantation. And of course, financial concerns. These are more expensive transplantation. That is something which we need to keep in mind. So to summarize, this is my last slide. Haplotransplantation, either with T-cell depletion or with post-transplant cyclophosphamide, effective alternate to those patients who do not have a matched sibling or unrelated donor transplantation. Newer strategies of depletion like this T-cell alpha-beta CD45RA may improve outcomes. I think we need to have more data on this. Post-transplant immunosuppression seems to be an important element in managing these transplants. So I think, whosoever of us embarks on a haplotransplant in thalassemia, I think this is a very important component of the preparation of these patients prior to transplantation. Careful selection of condition is very, very important. Post-transplant immune reconstitution and viral infections are still a very big concern, and that needs a very close follow-up and management. And the last but not the least, these are a learning curve, and these transplants, are evolving. We're learning with every patient, and there's a learning curve in handling these transplants, which I think we need to keep in mind. With that, I thank you, and I thank you for your attention, and I think I'll see if any questions are there before we move on to the next slide, the next presentation. Now, I'm not able to. Can the organizer stop my screen share? I'm not able to stop this screen share, unfortunately. I don't know why.
Yes, sir.
Yeah, please do that. So I'll just have a look at the Q&A. If there's anything burning questions to be asked, then we can do that. Okay, so there's a question that what is the dose of CD34 in T-cell depleted transplants which we use? So Chintan, we had done this. I didn't put that data here. We divided our cohort into 3 groups. Less than 10, 10 to 20, and more than 20. So to be honest with you, we didn't see any difference in more than 20 in the stem cell dose more than 20. So more than 20, in fact, we saw, as you rightly pointed out here, there was a little bit more CRS and also more GVHD, although it was lower grade GVHD, but it was more. So we have stuck ourselves to keep it less, between 10 to 20 and closer to 10, because that hasn't really shown any greater benefit than making it more than 20. Now, the other question is about. Okay, so the other question is what percentage of rejection can be reduced with this approach? So I think, Dr. Gagandeep, we have basically, whatever little data I showed you from Thailand and from our own experience, the rejection rates with post-transplant immunosuppression, pre-transplant immunosuppression, where they have been employed, has come to less than 5%, which was almost 30-odd% with the initial data when the PTIS was not used. So I think with PTIS, pre-transplant immunosuppression, the rejection rates in haploidentical transplantation setting can be reduced to less than 5%. But of course, that is all in the background of when you have done the proper donor selection, you have taken care of the donor-specific antibodies, taken the those donors who don't have against which you don't have donor-specific antibodies. I think then it's relevant in that case. So I think I'll ask some questions from the chat box to the experts in the meantime. Dr. Yadav sir, are you there?
Yeah, Sunil, I'm there.
So there's a question which I thought, maybe Gaurav will cover, but we can do it in the meantime. And that was on donor-specific antibodies. So there are a few questions, but I just consolidate all of them together. One is that what methodology we should use for donor-specific antibodies. Number two is that against what all, antigens / alleles you'll check the donor-specific antibodies. And what the third question is that what would be a significant titer in your experience?
So at present, like donor-specific antibody in haplotransplant is a must to be checked before taking up a patient for transplant, especially in non-malignant conditions, because the risk of rejection is quite high in these patients. They have a very immunocompetent marrow or very hyperactive marrow, and they can reject the donor cells pretty quickly. In patients with leukemia, they have been heavily pre-treated with chemotherapy. So in them, it's not that much a problem. So in thalassemia, particularly when you're choosing a donor, the patient should not have donor-specific antibodies. That's the best case scenario for that particular donor. And if there is no donor available, like if all the donors have antibodies present, then you should look at the one who has the least level of antibodies. So the cutoff most people consider is about 3000 MFI. That once the antibodies are more than that, then that's a bigger problem. Then if it's less than that, then those donors can particularly be considered. And but still, if the antibodies are present, you have to treat them and try to reduce them to as low as possible before taking up for transplant with that particular donor. In antibodies, one is you are checking for against each HLA, the antibodies of the patient, of the donor. A patient has the antibodies against each HLA. And HLA-DP, we are not checking these days as yet in my center. I don't know about other centers, but HLA-A, B, C, DR, DQ, we are checking. And then the antibodies against complement should also be checked. And but that's not easily available. But I think Lal Lab is going to set up or has set up. I'm not doing it in my clinical practice as yet, but that's something recommended that we should do. So that's about the antibodies part, and it's important. Over to Sunil. Yeah.
Gaurav, can you hear us now? Thank you, sir. Gaurav, can you hear us?
I think there is some problem with Gaurav's.
Gaurav's audio is a problem.
Maybe he can log in from his phone on Zoom, and we can.
Someone from MICE, please sort that out. I will continue with the next questions. So
this whole complement, the antibodies complement is probably the most important into the anti-cell antibodies, and Dr. Lal Path Lab is about to roll out the availability maybe in the next 6 to 8 weeks. I think this whole corona thing has delayed it, but by the next year it will be available, and this is the one which actually will tell that what this antibody is likely to do ultimately in the patient. It's very, very important, and Dr. Lal Path Lab is going to have this, and that will be available for the whole country because Dr. Lal Path Lab is everywhere. So that's good news for all of us, and they're going to.
Dr. Ganesh, are you there?
Ganesh is on mute. He has to unmute himself.
Please unmute, Dr.
Yes, sir.
Dr. Ganesh, a question which is again been asked is about, ethical, I would say, ethical discussions, ethical concerns in regards to thalassemia transplant. Not only in the haploidentical transplant setting, but also in the setting of siblings being donors, small siblings, weight discrepancies and all that. So how do we deal with that?
Thank you, Dr. Sunil. First of all, I would like to congratulate both the eminent speakers, Dr. Satyendra and Dr. Sunil, for such a wonderful, presentation and talk. Has been always a, lot of learning through your deliberations. Regarding the use of haploidentical transplant across not only the malignant indications but non-malignant indications, as Dr. Satyendra has nicely elaborated in his talk, and Dr. Sunil has reciprocated and also shared his experience of newer techniques, pre-transplant immunosuppression, and the conditioning, modulation, and post-transplant immunosuppression or GVH prophylaxis modulation. So the outcome, if you see the recent literature for last maybe 5-7 years, the outcomes of the alternative donor transplants, including the haploidentical transplants across different non-malignant indications, is at par with the matched sibling transplants. And without the transplant, the outcome of these children, particularly the pediatric population, is dismal. The Satyendra has nicely highlighted in his in his presentation and his slide set that the overall survival was around 20 years or less in the thalassemia major. And recently, I'm not talking about just in India, but across the globe, the most developed countries where the conventional non-transplant care, including regular transfusions, iron chelations, which is the optimal thalassemia care for that matter. Despite that, the long term, the overall survival hardly is second or third decade. So compared to that, the transplant is the only therapeutic option which offers the curative potential in these. So this is the most important message for that matter. I just half an hour back I was going through the literature. Even today, just a June 2020 publication by the American and the European collaborative group on the various ways to modulate haploidentical or alternative donor transplant in children with thalassemia major in the countries where thalassemia care is absolutely optimized. It's not like, I'm sure all of us, the eminent panelists, the eminent speakers and eminent teachers on this platform will agree with me. Out of 100, not even 5% thalassemia major children in our country gets the optimal thalassemia care. Compared to that, even in the developed nations like the Western countries like North America or Europe or Australia, whatever it is, just a recent publication, June 2020, BBMT, Biology of Blood and Marrow Transplant, modulating trying to modify the protocol, conditioning, pre-transplant immunosuppression, post-transplant GVH prophylaxis. The outcomes are at par with matched sibling transplants. And that's the key message. If you want the children to be completely thalassemia free, leading a meaningful life with a reasonable life expectancy, I think this is the future. And we have eminent transplanters on a national platform. Yeah, Satyendra, I can see your.
I just want to add one question, So rather than asking this question from that side of the table, I want to ask the people onto that side of the table that not offering a cure in a country where patients are not getting the standard of supportive care and giving them, let us assume that even in India, the matched sibling transplants are low risk are 85 to 90% and the high risk are 70%, and the haplotransplant are producing 70%. Now, you want to play the god and you want to give you don't want to give the chance of cure to these patients. Is that ethical? If a family wants to take that call, that no, I want my child to live a normal, meaningful, happy life, and I want this transplant, and denying them the transplant, is that ethical? That is not ethical, right? So whatever cure is there, if the family wants, if it is not experimental, should be given to them. And this is not an experimental treatment. Now, I have heard a few talks now recently that even for matched sibling, there are few people who will stand into a meeting and they will ask a question. Should we have a matched sibling transplant also for the thalassemia patient when we are seeing that the thalassemia patients are going to become the pilot also, this doctor also and all that? Come on, guys, start, that's not the truth. only 2% of the thalassemics are getting into the third decade in our country, right? So taking the survival data from the Western world, and then guiding our patient that, let us assume that the supportive care is of the Western, that's absolutely double standard of us, right? We do not give better supportive care, and whatever good available is the cure, and that should be offered. That's what I want to say.
Point taken, Sajid. I think it's a complex discussion. It needs to be
Sunil,
discussed with the family.
Dr. Sunil,
Oh,
can I
hello.
just get 30 seconds?
Am I audible now?
Before we go to the
Yeah.
discussion, I just wanted to another important, because this is an August audience, who, the pediatricians, the physicians, the message has to be clear and precise. See, every transplant, Satyendra and Sunil have nicely elaborated in their, deliberation that, in transplant, now we see this figure, Professor Donald Thomas, the father of transplant across the globe. So transplant is a learning curve, even for match sibling transplant in the era 60s, 70s, 80s, the long-term survival, post-transplant survival used to be 20, 30, 15, 20, 30%. The same is true for the haploidentical transplant also. Even for malignant indications where it's a desperate situation, the survival used to be 10, 20, 30. But now, with the learning curve, the survival is 50, 60. So for every disease, the learning curve, unless and until we keep on learning and keep on, continuing with the whatever is the, science or literature based, evidence based practice, we won't be able to succeed in clinical practice, even for, across, benign as well as malignant hematological indications, including thalassemia. Thank you.
Thank you.